So welcome everybody today to the live scanning session on endometriosis. This session is sponsored by Canon for ISUOG virtual meeting, which originally was going to run from Glasgow, but it's so great to see so many of you in your rooms from multiple countries from around the world streaming in live today to watch us perform this deep endometriosis ultrasound scan. Canon has provided us with an amazing machine, the Aplio i800, and so we'll be going through some of the technological advances in relation to this machine whilst performing in real time an ultrasound looking at all of the different forms, the different phenotypes of endometriosis following the IDEA consensus statement. You will note today that during the ultrasound scan, we will not necessarily follow the 4 steps in chronological order that are published in the systematic review that we published in 2016 in the UOG, but by the end of the ultrasound scan, we would have completed the scan in a chronological way that enables us to not only map disease location, but also the extent of endometriosis, which is critical when planning surgery. Another aspect of the ultrasound today is we're doing this ultrasound scan in a young 23-year-old woman who's Virgo intacta. So we're performing this scan transrectally, and I think this is an important learning for all of us, where we potentially have the ability in young women who've not been sexually active to get exactly the same information that we can using a transvaginal scan by doing a transrectal route. So this is a really, really important advance when it comes to visualizing both the structures of the pelvis, the anatomy of the pelvis, but also locating the disease. This is a 23-year-old young woman who's had symptoms, significant symptoms in relation to bowel pain, dyschezia, no rectal bleeding for the last year to 2 years, but on questioning her in greater detail, she's actually had symptoms for quite a while. So when the scan starts today, so the probe's been inserted into the anal verge, and we followed the muscularis in a cephalic direction. And one of the first things that we come across on the ultrasound scan itself is we can see that there is indeed a rectal nodule that's present. So what we'll do is, in accordance with the IDEA consensus, we'll measure that nodule in 3 planes. So we're in a mid-sagittal position at the moment. So it's a nodule that's 11.7 millimeters by 7.1 millimeters. And then we'll come to a transverse view. And it's really important when doing the endo scan to try and get as much information, additional information out of the ultrasound scan, other than just looking specifically at the uterus and ovaries. So that third measurement, 7.2 millimeters. As we follow that lesion, we can see that in real time as we gently move that probe back and forth up against the lesion. So we're in great proximity to that lesion. You get the impression that that pelvis is fixed. So there's very little movement between the lesion itself and the, you can see that bright white pleomorphic reaction that's probably superior to the vagina. And so that rectal nodule itself is fixed with a surrounding pleomorphic reaction in the pouch of Douglas. And to the left on the screen, we can also see that there's an endometriotic lesion itself. So first thing we can say in this young woman who to date did not have a diagnosis is that she's got rectal endometriosis. And so we will now obviously evaluate the rest of her pelvis to see whether or not there's other signs of endometriosis. And if we go back to that rectal nodule, you'll see that, and according to the IDEA consensus, you can see that almost concertina effect as the bowel is drawn towards, you'll see that layered effect. So as the rectum itself is drawn towards that lesion, so you get that pulling of one's sleeve sign that's described in the IDEA consensus statement. There's a really nice view of that there. So we'll continue to, as best as possible, to try and go cephalically, following that rectum as cephalically as possible. And you can see that the rectum's folded on itself due to the presence of that rectal endometriosis. So you get that external fibrotic reaction, pulling that surrounding rectum towards the lesion itself. So as we move that probe cephalically, and we can get a really good view of the anterior muscularis. And my feeling is that we've got a unifocal, so there's a single lesion within the rectal wall itself. So once we've established that we have a rectal lesion, then we focus our attention on the uterus And we want to obviously determine if there's any adhesions, rectouterine adhesions between the lesion itself and the surrounding structures. We can see that there's some fluid in the pouch of Douglas, so it's a great time to scan someone, particularly second half of cycle, so in the luteal phase. And the fact that there's some fluid there tells us that it's very unlikely that the pouch of Douglas is going to be completely obliterated. So there may be a degree of partial obliteration on the side that the nodule's on the left side. So we can see that that nodule's fixed to the left, probably uterosacral lesion. So too is the left ovarian endometrioma. So we've got partial obliteration to the left of the midline, and as we move that probe towards the right, we can see that there's some fluid present and the rectal wall itself moves more freely. So we've got a hemipelvis, preferentially on the left side, that appears to be obliterated with the presence of rectouterine adhesions. Then we come to the uterus itself, and it's highly unlikely in someone who's nulliparous to have any signs of adenomyosis, but it's important when looking at the uterus that we apply the Musa consensus rules when it comes to determining whether or not there's any changes to the myometrium. So we want to look at the symmetry of the myometrium. We want to see whether there's any presence of endometrial or myometrial cysts. We want to look for diffuse linear striations within the actual muscle wall itself, look at the vascularity of the muscle itself, see if there's any budding within the as the endometrium infiltrates into the muscle itself, and then we would get a nice 3D view, getting a coronal view at the end, just to make sure that there's no disruption of the junctional zone. So we've got a nice power Doppler view there of the uterus in mid-sagittal view. And I think that the myometrium itself, from a echogenicity perspective, morphologically speaking, I think looks fairly uniform and homogeneous. There doesn't seem to be any obvious infiltration of the endometrium into the muscle itself. You can get discrepancies with the actual myometrium, particularly when there's myometrial contractions. But in this situation here, I think that the difference between the anterior and posterior myometrium is negligible. So I think there's no asymmetry per se. What we will do whilst we're in position there, so you can see the cervix, we can see the endometrioma, I think that's on the left side. As we gently press that probe up against the cervix, and if we maybe zoom out just a little bit, and press that probe against the cervix, you can see quite clearly that although there's movement within the bowel contents itself, there's no movement between the bowel and the surrounding cervix itself. And you can see that just behind the cervix, we bring up the arrow to the right on screen of the actual endometrioma, we can see that there is a hypoechoic lesion just there, and that's probably, we'll measure that and probably come into view, but that may well be within the vicinity of the torus uterus. So where the two uterosacral ligaments converge in the midline, this is the origins of the uterosacral ligaments. This is the torus uterus. So we've got a torus uterus lesion itself. The ovary is fixed to that. The bowel is also fixed to the vagina, fixed to the cervix, fixed to the torus uterus itself. And we know that this fixation is preferentially midline and to the left of center. So we're already starting in our minds to construct a view as to what this may well look like at laparoscopy, and bringing together the technologies of advanced endometriosis ultrasonographic skills and complementing those with the ability to perform high-level laparoscopic surgery is a perfect blend, a perfect mix. So there's such complementary modalities. We're using non-invasive imaging to classify endometriosis, and then that helps us to decide the severity of the disease. We can, using tools such as the UBEST tool, determine whether we think that this is going to require complex laparoscopic surgery, which indeed it is. And now we're looking specifically at left uterosacral itself, so we can see that ovary is fixed in the midline to the torus, and also to the left of center to the uterosacral disease on the left side. So not only do we want to be able to look at and describe the individual lesions from a deep endometriosis perspective and describe these measurements in 3 planes, looking at the ovaries themselves, but more importantly, we want to know if there's distortion of the anatomy and whether indeed there is the presence of adhesions, which in turn means that you're very likely to have more complex surgery that involves exploring the retroperitoneal spaces, the avascular spaces within the pelvis, to restore the anatomy at the start of the procedure before we actually move on to starting to excise the disease. And it's probably a little bit more, this is just re-highlighting the left uterosacral lesion just there. It's quite good also to use power or color Doppler, because sometimes you can get some vascularity as you sweep that probe, which is sitting now in the posterior vaginal fornix laterally towards the uterosacral ligament. Sometimes you can misclassify what appears to be a hypoechoic lesion with some blood vessel itself. So a nice trick when it comes to determining whether or not indeed this is a true left uterosacral ligament deep endometriotic nodule, which I think it is in this case. So we're still looking in the posterior vaginal fornix. We're now swinging from the midline over towards the right. This is the peritoneum of the pouch of Douglas. And you can see within that peritoneum, there's also a hypoechoic lesion coming into play. Just in this area at the anterior, just below the vagina. Yeah, there. So are we in the midline here? We are indeed, or just to the left of center?
To the right.
To the right. And so this is probably the beginning of the uterosacral ligament on the right side. And so we've got some uterosacral disease here as well. So again, a clear hypoechoic lesion within the uterosacral ligament itself. We published a descriptive paper on the classification of uterosacral disease, which is a free download through the Australasian Journal, so quite worthwhile looking at that so that you can get an understanding of how you can classify uterosacral disease in relation to parametria laterally and torus uterus medially. So we can see there that we've got quite significant uterosacral disease there, both mid-sagittally and then in the transverse view. And again, we've brought the colour on just to ensure that there's no obvious blood vessel there, which indeed there's not. And the bright whiteness or that pleomorphic reaction that you can see around the nodule, that is part of that fibrotic reaction that you see in response to the endometriosis. So we know that there's going to be a thickened uterosacral ligament. On this side, it looks like the pouch of Douglas is probably free, so we've got some fluid present, and the bowel moves quite freely up against that uterosacral ligament as well. So that fits with a diagnosis of partial obliteration to the left of midline. We can also see that that left ovary, which contains a unilocular cystic lesion. This one here. This is the right ovary, which is looking relatively normal. So we'll look at that up close just to make sure that there's no small endometriotic lesion within that ovary. And I'm very fortunate today to have one of my colleagues, Dr. Mercedes Espada, who's worked with me at Nepean Hospital for the last 4 years and now has started her consultant career here at Nepean Hospital. And so she's kindly doing today our transrectal ultrasound scan, having had a wealth of experience, having worked in Spain prior to coming to Australia. So that right ovary looks relatively normal to me, but we can see next to the ovary, we can see a unilocular cystic lesion that potentially has incomplete septi, and this may well represent a swollen tube or a hydrosalpinx that could well be related to endometriosis at the distal end of the fallopian tube. In someone that's not had intercourse before, we know that this is not going to be related to any sort of STI or otherwise. So we've got potentially a right-sided hydrosalpinx. The right ovary itself from a mobility perspective, and it's important to assess that. It looks like there's definitely movement laterally against the left pelvic sidewall, which is great. Obviously that hydrosalpinx is enveloping the ovary, so there's a degree of impairment of movement there. And the bowel moves freely up against the outside of that hydrosalpinx itself. So when we assess ovarian mobility, we're going to look at ovarian mobility in 3 planes: laterally against the pelvic sidewall, medially against the uterus, and then inframedially against the uterosacral ligament. And the ovary doesn't seem too bad. So apart from the potential right-sided hydrosalpinx, that looks relatively good. When we look at the mobility of this large endometrioma, which is probably filling the left hemipelvis and also the pouch of Douglas itself, there seems to be a degree of fixation against the uterus itself. And we'll measure that endometrioma on that left side. So it's around 40 millimeters by 52 millimeters. And we'll get that third measurement as well. By 43 millimeters. And again, we'll assess that mobility of the ovary. And we know that from preliminary data that potentially those ovaries that are fixed, particularly inframedially to the uterosacral ligament, are more likely to require blunt dissection at laparoscopy. And if there's going to be appropriate removal and clearance of disease, and we know that that's best done at the first surgery if we're going to get the best long-term results, then this woman's likely to undergo a ureterolysis on the side of the endometrioma, so that it's going to be then possible to ensure that that ovary is mobilized appropriately, and then we can remove the pelvic sidewall on that left side if there's any potential fibrosis or fibrotic reaction or superficial endometriosis underneath that ovary itself. Once we've done that at surgery, that also enables us to mobilize the rectum by opening the pararectal spaces. So we've got a left ovarian endometrioma that's filling the pouch. It appears to be fixed to the uterus. We've also got a rectal lesion that's fixed to the posterior cervix and also the torus uterine. We've got bilateral uterosacral ligament disease. And there's a degree of fixation of the ovary in relation to the torus and potentially also the uterosacral disease on the left side itself. So then we're going to move into the anterior compartment. And we can see quite nicely there that the bladder that's abutting the uterus is the base of the bladder. And so preferentially, if there's any deep endometriotic lesions of the bladder, it tends to be within the bladder base itself. But we can see quite clearly here that the bladder base looks free of disease. What we usually do to visualize the ureter is we reverse and invert the image. That's great. So now we're in an anatomical situation. We've got the probe in the anterior fornix, and as we swing to the right, we can see coming into play beautifully is the right ureter. So we'll put an arrow onto that, and you'll see quite clearly in a minute with some patients. When you put color on, you can see that it's not vascular itself. And so I usually get patients to have a cup of tea or coffee an hour before the scan, so that even though the bladder's emptied before the scan, we get a good degree of vermiculation during the scan. And we follow that ureter proximally. You can see it right the way there, back to the pelvic brim. So hold that there and we'll see if we can get some vermiculation. We've looked at the systematic approach to uterus, ovaries, ovarian mobility, sliding sign to assess pouch of Douglas. And we've also looked at the different potential locations based on a compartmental assessment of the pelvis anteriorly and posteriorly. We're fortunate now today to demonstrate our ability to visualize superficial endometriosis. Because this young woman has some fluid in the pouch of Douglas, we can see here that over the serosal surface of the rectum, you can see that there's a small tag coming into play just there, and it's almost literally like a flag waving in the breeze, and that would represent some superficial endometriosis over the surface of the rectum itself. And here's another area here. And so when you look at down the laparoscope, you'll see that the surface of the bowel itself has these vesicular lesions, which we can see on ultrasound today by virtue of the fact that there's some fluid in the pelvis that creates a standoff technique or a standoff field of view, so to speak. So there's some signs also of some superficial endometriosis cephalic to the deep endometriotic lesion that we saw earlier in the scan as well. So fluid in the pouch of Douglas can be seen if you scan someone in the second half of the pregnancy. We've just published on a new technique called Sonopodography, where we replicate this in an in vivo situation where we put a saline infusion catheter into the uterus. We instill 20 to 30 mils of saline. That saline passes through the fallopian tubes, sits in the pouch of Douglas, and enables us to see quite clearly the peritoneum of the pouch of Douglas, the rectouterine pouch itself, and we can look for hyperechoic lesions, adhesions or otherwise, which based on our publication and looking at gold standard data, we can pick up 80% of women with endometriosis, superficial endometriosis in the pouch of Douglas, in those women that have no signs of any other phenotypes. So a great advance in our ability to potentially visualize superficial endometriosis, which previously has not been described. So we can see that those areas there are superficial endometriosis over the surface, the serosal surface of the anterior rectum. And so to close, I would like to obviously thank our patient today, who has been incredible. Obviously, the team at Canon have been incredibly professional as well, and my colleague, Dr. Mercedes Espada, for performing the scan, which again gives us a great insight in our ability to visualize the pelvis, but from a transrectal route. So enjoy the rest of the conference, and we look forward to seeing you online. Thank you.